We're going to go to our next session now, and my ESIS colleague, the fantastic Lisa Hume, is going to introduce Dr. Kat Noble. Over to you, Lisa. Are you there?
Thanks, Pete. I am here. Can I just do a sound check? Can you hear me?
We can hear you. Pip, if we can put Lisa and Kat's cameras on, that would be great.
Yeah, Lisa, you've been made a co-host. You as well, Kat. Oh, there we are. Success. We can see you.
Okay, can we just do a sound check for Kat? Are you there, Kat?
Yes, I am.
Lovely, thank you very much.
Perfect.
Okay, so welcome everybody, and thank you for inviting myself and Kat along to talk about all things 111 today. So I would just like to do a bit of an introduction to my colleague today, Dr. Kat Noble. So Kat is a GP specialist in emergency care, and she's worked clinically in GP, urgent care and emergency department settings now for 16 years. She first became involved in 111 back in 2009 when she was part of the County Durham and Darlington single point of access pilot for 111. She then became National Advisor for the Department of Health, going on to co-design the national assessment process for 111 providers with Dr. Nicholas Reeves. And then in 2012, she became the National Medical Director for NHS Direct, and in 2013, the Co-Medical Director for Nhs Pathways. And now, while still working clinically, she holds roles as a CQC inspector, an ESIS clinical associate, and she's also the Associate Medical Director for 111 with North West Ambulance Service. So I think that totally qualifies Kat to talk about the subject matter today. So welcome, Kat.
Thank you very much.
We've got no slides today, guys. We're just going to jump straight in and start some discussion and debate. So do feel free to throw any questions in the chat box if you have any. So, Kat, I guess a great place to start today would be just to tell us a bit about the 111 service, really. If you could give us a brief history and in simplistic terms tell us what it's all about, that would be great.
Yes, of course. Well, thank you very much for inviting me. I guess, and the first thing to say is 111 land is pretty complex, is pretty complicated, and it's often a topic which generates a lot of opinion. So please do chip in terms of the chat box, and if there are any sort of, evidence out there from the first followers and so on, we'd really love to hear from you, because every day is a school day in 111. So in terms of history, 111 actually started back in 2007 with the Department of Health document, Our NHS, Our Future. And that was the document which said that non-urgent care should have a 3-digit single point of contact for everyone to be able to access. Ofcom then appointed the 111 number in December 2009. And in August 2010, that was when County Durham and Darlington, but also Nottingham and also Luton were the first pilot sites, the single point of access sites, the precursor to 111. I guess by way of background, it's useful to know the 111 essentially sort of replaced NHS Direct largely. NHS Direct was fronted by nurses. It remains an outstanding brand. It amazes me. I still see documents, pamphlets around about hospitals which still quote NHS Direct. And the public sort of loved NHS Direct. However, demand was outstripping the capacity to be able to deliver that service. And so there was this kind of recognition that urgent care could no longer be fronted necessarily by clinicians, and demand needed to be soaked up in another way. And so that came to be that clinical decision support systems became part of our service. And essentially they were sifting and sorting demand, meant that they were supported systems, so they could largely, not always, but largely be fronted by non-clinicians. But of course, there is always an element of clinical support in the background. So the largest clinical decision support system is Nhs Pathways. And just to finish off that history, it was Andrew Lansley's parting gift that in 2013 he landed 111. So all of England went live with 111. Difficult times. I think there was kind of strong clinical opinion about that being done unto us. And also slightly hampered by the fact that the communications budget within the Department of Health was pooled, and so there was no communications round about that that change to our service, which again made for tricky times. And I think actually 111 has struggled to regain ground from a brand point of view since. But of course, it's now huge, and it's about to become even more huge, and it takes sort of in excess of 5 million calls a year, so absolutely vast, and a vast potential for data and for health intelligence. So I think the 111 has obviously become kind of common parlance now, and with Think 111 First. And I think everyone kind of assumes that we know what 111 is, but I'm going to indulge and really kind of go back to real basics about what 111 is and what it isn't. Hopefully because that will help people understand, it will help people be able to understand where the blockers are in terms of their own systems that they may or may not be coming up against. And so essentially 111 is the telephone number, and that's all it is. But after you phone that telephone number, most often you encounter an IVR, so an interactive voice response. And that's where you get an element of choice, and that has developed since. So for instance, that IVR may include options to choose. If you're a healthcare professional, you want to speak to another healthcare professional, or if you're speaking about if you're phoning about a dental call, you can be routed straight through to dental practitioners, or indeed you could be assessed. Now, that isn't an element that there are various private companies that offer very sophisticated IVRs, which may be something to watch out for. After you get through the IVR, and if you are going to be assessed, then that's where the clinical decision support system comes in. And it's response driven, so that's why you want to speak to the person ideally and not a third party. It's not something that you can say, show me the pathway for back pain, because that doesn't exist in isolation. It depends on what the person has said before. It depends on the supporting information that the call taker introduces, etc. But the end point is you end up with an outcome, which is a mix of a symptom group and a symptom discriminator code. And that roughly tells you what clinician could meet that need, and roughly in what time frame you might need to see that clinician. It then passes to the DOS, the Directory of Service. And this is where the SDs and SGs are matched. And this is a particularly critical part because that matching is local commissioner led, and it requires that they detail their services in enough detail to be able to create the best options locally available for those patients. So for instance, if a DOS isn't updated that an urgent care centre closes at 8 p.m, then the system will carry on feeding people through to that service. And also the backstop is if the DOS can't match that call with anything, then your backstop is that call gets referred to ED, so that's your no returns. But of course, the service is supported by clinicians, either floor walking, actually, virtually, and that is a whole grade of workforce, which the NHS England produce a workforce deployment programme around. So that really, in essence, in a nutshell, it is the simplistic view of 111.
That's great, thank you, Kat. Can I just do another sound check there, because I know I'm being advised that I've got video problems. Can people still hear me?
Lisa, we can see you and hear you now. Perfect.
Okay, great. Thank you. Okay, thanks for that, Kat. That was a really useful history to get us all to the position. So, just in light of where we've been and now where we're going, the national agenda for 111 first. Can you tell us a bit about that, and then we'll come on to have a discussion around some of the published evidence that's out there?
Yeah, of course. So, everyone will be coming very au fait with the Think 111 First, which is a national ask. Essentially, the specification is kind of built round about a kind of a learning and a response sort of post-COVID. It does stress that the first point of contact for patients should either be their GP practice or 111 in obviously urgent but non-life-threatening situations. It talks about remote assessment, remote working, the use of technology, the reduction of travel to physical locations, particularly reducing or minimizing the potential for overcrowding in EDs. It also talks about protecting the most vulnerable groups of patients, and particularly mental health. And I'm sure, you know, as a clinician, and all of you listening as clinicians will be slightly daunted at the wealth of mental health issues which are now creeping out post-COVID. It talks about 111 having the potential to directly book into services, including EDs. It also talks about local services doing the comms, the communications to the public behind this work, and also about sort of clinically validating all ED dispositions which are appropriate to validate. So there are first follower sites which are going, and I would love to hear from some more of those, and some of this talk builds on EKIST's team and the feedback and the vigorous discussions that we've had over 111 so far. However, the specification does say that all services need to deliver this by December, as in December this year.
That's great. Thanks for that, Kat. So we have got some questions in the chat box, but I think before we move to the questions, just around the published evidence that's out there, because as you say, we did a bit of a sense check with some of our colleagues within ESIST over the weekend, which generated some really interesting and healthy debate around all things 111 and certainly the 111 First agenda. So can you tell us just a little bit around published evidence, and then we'll pause there and try and answer some questions.
Yeah, okay. So for the published evidence, I'm going to reference Jen Lewis, who's part of Sue Mason's team from SHAR, who produced a really chunky bit of evidence. They looked at 3 million 111 calls ranging from 2013 to 2017. Looked at ED attendances, the hospital admissions up to 7 days after the 111 calls. And just the very high level detail, although I've just heard back from Jen actually that they're about to publish something more, is that essentially in the service that they looked at, less than 10% of patients were told to go to ED. However, 23% of callers did. But the next bit for me is more interesting. Of those who attended ED, some of whom were told to, some of whom were not, they looked at the disposition that had been reached within 111, and it seemingly, regardless of disposition, so whether it was primary care right through to ED, roughly 30% of each of those groups ended up being admitted. Which for me makes me question the clinical decision support system and the pace of evolution of it. I guess there is an argument that data was from a sort of pre-CAS, pre-clinical assessment service era, and with integrated urgent care contracts and so on, things should be more joined up. Calls should be validated. However, I understand from NHS Digital colleagues that a similar bit of work was repeated in 2017-18 that found, excuse me, much the same thing. So I think very interesting evidence for us to factor into Think 111 First agenda.
Absolutely. Brilliant. Thank you for that, Kat. So I think we've got 5 minutes till the end, and I am aware there's a few questions. So Pete, could you advise us of the questions, please?
I can. So the first question is, from Siobhan. We're interested in increasing direct bookings, but technical processes within 111 don't really support this easily. How do we move this forward?
Yeah, okay. He's speaking to a clinician, not to a techie sort. So might be limited in how I can respond to that. All I can, I suppose, say is that there are challenges with the technologies which interface between 111 services and hospitals and so on. There are also challenges, I guess, in terms of the buy-in of services to allow direct booking. Obviously, direct booking was first started into GP practices, and there was really quite a strong pushback for GP practices in allowing that. But actually, the evidence now is more that the appointments that are offered aren't actually used. So yes, I'm sure there are technological challenges about that. Offering it makes entire sense, because I think this is one of the problems in urgent and emergency care, is that we have lots of services involved, but no one actually takes proper responsibility for sorting out the next step in that patient's journey. And that's when patients circle around our system, I feel. So to be able to offer into appropriate services which are governed by local commissioners and kept up to date by local commissioners is utterly key to deliver an effective patient outcome.
Right.
Thank you, Kat. Siobhan, I would just add into that as well. I'm not sure which region you are working within, but the Midlands NHS E and I regional team actually have an NHS Futures platform that has a 111 page as part of that platform. So I'm sure if you wanted to join that, it's got a really good discussion forum on. You could maybe post a question and link in with colleagues from the Midlands if you're outside of that area. Okay, I think we've got a couple of minutes left. So is there another question, Pete?
I'm going to pick one question. Apologies to Rob for not picking his, but this one's from Joe T. Do you think the phase 1 asked for the 111 rollout by December the 1st will achieve change in emergency flow or patient behaviour, Kat?
Cracking question. Yeah, I think one of the issues or potential challenges I see with the specification is perhaps the lack of connectivity with primary care. If we're talking about kind of whole system and how we all deliver urgent emergency care, then there's something in there about an equitable assessment process and about reproducibility of that assessment process. I think the way things currently work with primary care being asked to carry on doing what they're doing, however, there aren't enough GPs and the ask is even bigger than it was last year. For that to be not joined up in terms of what we're asking 111 to do is an obvious omission, and don't get me wrong, I don't think that it's an easy thing to do, but I think unless that's joined up, then we will continue to have this kind of inequity in the system. So we will not get the correct flows of patients going into urgent emergency care. But it's a great question, one that we could debate for ages.
Yeah,
absolutely. Yeah, thank you, Kat, and I'm sure that we will have future debates within the team around this also. So big thank you, Kat, because I know you haven't been 100% health wise today, so thank you for joining us and being so engaging and interactive with the crowd. And back to you, Pete.